with Professor Kavga. Professor Kavga is from Thessaloniki, from the Aristotle University, and is a professor in pediatrics, pediatric cardiology, in Pokratio General Hospital. The topic is comorbidities in children suffering from severe forms of congenital heart disease.
Good afternoon. Can you hear me?
Yes, very well.
Okay, I will share the screen. Okay. Okay, can you see the presentation?
No. Not yet.
Okay.
It's okay now.
Share?
Yes.
Yes.
Yes, can you see it? Okay. Full screen?
Full
And
screen.
can you see all the, can you see it? I mean,
Yes.
It's okay
Yes,
now.
it's okay
Okay.
now, Maria.
Okay, thank you. So, good afternoon from Thessaloniki. First of all, I would like to thank Professor Kalagos and all the organizing committee for this kind invitation. I am glad to participate in this Congress. Also, I would like to congratulate them for this initiative and the high quality Congress. I have been impressed and apologize for not being able to be there in person due to family reasons and busy schedule. So within the next 20 minutes, I will try and speak about comorbidities in children suffering from severe forms of congenital heart disease. So patients with congenital heart disease face comorbidities at all ages. And indeed, comorbidity rate is high in childhood and according to literature, reaches 90%. And as we can see in this figure, comorbidities are higher in children than in adults, and at least 36% of children have got one comorbidity, at least 30% of children have got two comorbidities, so one or two comorbidities are very frequent in children with severe congenital heart disease. The largest number of comorbidities in childhood is 7, while on the other hand, half of adults have no comorbidities at all. And what kind of comorbidities do we have? Common comorbid conditions include diseases from various systems. For example, we can have lung disease, we can have liver disease, especially in patients after Fontan operation. We can have immune diseases, especially in DiGeorge syndrome. We can have asplenia in children with heterotaxy. We can have erythrocytosis in cyanotic congenital heart disease. We can have airway diseases, endocrine diseases. Almost all systems can be impaired in children with congenital heart diseases. Most frequent comorbidities are perinatal conditions. And as we know from the literature, children, infants with congenital heart disease are more likely to be born premature and with low birth weight. Around 10% of children with congenital heart disease suffer from prematurity, and due to prematurity suffer from neonatal complications such as respiratory distress syndrome, bronchopulmonary dysplasia, enterocolitis, and also due to high energy demands, it is difficult to gain weight. As children grow, key comorbidities change, and mainly they suffer from arrhythmias or neurodevelopmental delays. Also, what we know from the literature is that between 25 and 30% of children with congenital heart disease have some form of extracardiac anomaly that may or may not be immediately apparent. And if we would like roughly to group extracardiac associations, we can say that they suffer from genetic syndromes, structural malformations, or metabolic associations. I will not get into details because you are all aware of these syndromes, but I would just like to remind that a large number of known genetic syndromes have a cardiac defect as part of their typical dysmorphic spectrum. Also, there are several well-known structural malformations that are associated with diverse congenital heart disease. For example, abdominal wall defects, congenital diaphragmatic hernia, limb malformations, and they can group together, recognized like a syndrome, Chard syndrome, for example, or they can be individual. What is important is if we find one element of a malformation, then the child, the patient, should be investigated for the presence of the other known defects. And why do all these comorbidities matter? The answer is simple, because they have got a clinical impact. Congenital heart diseases, when associated with any comorbid condition, may complicate both the outcome and the management of the patient. And in order to make it more realistic, I will share with you a clinical scenario. Let's describe a 3 week old neonate that is in front of you and has got cyanosis, but also has got deep jaundice. So you suspect tetralogy of Fallot, but also you suspect biliary atresia. And you are right, because genetics come back, and this baby has got Alagille syndrome. So what is the next step? Should this baby be offered repair of the tetralogy, or does the decision depend on the outcome of his Kasai operation? And who makes the choice? Does the decision depend on a favorable cardiac prognosis or liver prognosis? What this case teaches us is that congenital heart disease can be a scary scenario when other pathologies, comorbidities are present. And in literature, it resembles Pandora's box. So the co-occurrence of congenital heart disease with comorbidities in childhood often raises difficult ethical dilemmas, like the case before. But what is read and what is known is that surgery for congenital heart disease should be considered in cases where the congenital heart disease may improve the functionality of the child and its family. And of course, in recent years, the reduction of perioperative mortality due to improvement in cardiac surgery has been remarkable. But when we say surgery in congenital heart disease with extracardiac anomalies, this combination continues to lead to higher morbidity and mortality figures, and of course, worse neurodevelopmental outcome. It is known from studies that the surgical mortality of congenital heart disease surgery of children with extracardiac anomalies that were mentioned before may be as high as 60%. And the key elements, the key risk factors, are the severe congenital heart disease, especially when we speak about single ventricle physiology, the younger age, less than 1 year of age, when the procedure is done in an urgent basis, and of course, the coexisting genetic or extracardiac abnormalities. And if we are wondering if we can calculate these things and have a predictor in order to see if we can predict in hospital mortality and morbidity in pediatric patients undergoing congenital heart surgery with comorbidities, I found in the literature, and I'm not a surgeon, the surgeon would say if they use it or not, this risk adjustment for congenital heart surgery scoring system that seems to me a valid tool to see if the mortality rate will be if the mortality will be bad or not in these children. And this is a score that includes the procedure, if the procedure is low risk or high risk. It includes the age, so the age is a comorbidity if it is a neonate, the prematurity. Babies born prematurely often have higher surgical risk due to underdeveloped organs, and of course, the major non-cardiac structural anomalies, extracardiac anomalies, and of course, the number of operations, complex procedure, and the staged operation, it typically increases the risk level. What is the impact of the weight of the child in children with congenital heart disease? The answer in the literature is a bit controversial because it says that low birth weight is another comorbidity and has demonstrated association with increased morbidity and mortality. However, there is no sufficient evidence that delaying surgery improves outcomes. So some other authors, some other studies feel that delaying surgical intervention, even if you have comorbidities, maybe lead to additional morbidities. So I found this table saying that potential indications for delaying congenital heart disease surgery when there are comorbidities is sepsis, end organ failure, and active bleeding. The Columbia model also shows us that even if the mortality rate, what they do in Columbia, they have got a neonatal cardiac program, and they do surgeries in infants less than 34 weeks of gestational age, and they published their data. And they found that if the congenital heart disease is isolated, the mortality rate is low, even if we speak about prematurity. But when there is a syndrome, a genetic diagnosis, or an extracardiac anomaly, this mortality rate gets up to 35%. So they highlight the influence of comorbidities, including genetic diagnosis, on survival outcomes. Beyond perinatal period, as children grow up, pneumonia and heart failure remain common comorbidities both in simple and complex congenital heart disease, mainly in acyanotic congenital heart disease. And as we go to adolescence, we find that neurodevelopmental delay is the key comorbidity in this age. At least 50% of adolescents with congenital heart disease are at higher risk for developmental delay, learning disabilities, attention deficit disorder. And why that? Some risk factors, of course, include chronic hypoxia, surgical interventions, multiple surgical interventions, reduced cerebral perfusion. We all know that cardiopulmonary bypass is a risk factor for vascular strokes, even mainly in children with cyanotic heart disease who require multiple palliative procedures. But what we know now from research and literature is that the fetal brain and heart develop simultaneously, sharing common genetic pathways. So there are some studies indicating that this neurodevelopmental delay may be due to genetic factors, not only the consequence of cyanosis and hypoxia. And there is great evidence in literature about the brain development in utero. So some authors state that structural changes in the heart from congenital heart disease that lead to cardiovascular physiology can lead to altered blood flow affecting brain oxygenation. So we have got cardiac physiology, we have got genetics, we have got complex surgical procedures, so the outcome is neurodevelopmental delay later in their life in kids with congenital heart disease. With improved surgical outcomes, children with congenital heart disease will either die from the congenital heart disease, but maybe they will die from other comorbidities. And for example, according to this study, within shunt type and valve type congenital heart disease, children less than 1 year of age, they will die due to respiratory disease or due to infectious disease. And why does this happen? Because lung disease, in their case, reflects development of abnormal lung parenchyma as well in children with congenital heart disease. And also children with severe congenital heart disease face hypoxia, face acidosis, and this chronic exposure of pulmonary vasculature to these things, this can lead to pulmonary hypertension and increase the risk of death. And on the other hand, we are aware that many invasive procedures, central access necessity, will increase the risk of death. And always, we do not have to forget the risk of endocarditis in significant hemodynamic congenital heart disease. Another study from Norway, what they did and what they say, they tried to find out factors associated with risk of death after cardiac surgery in severe congenital heart defects. And what they found is that unexpected deaths unrelated to cardiac unexpected deaths were infrequent in children younger than 2 years of age if there is no comorbidity. But children are at increased risk when there is a comorbidity, and they state comorbidities like prematurity again, the staged cardiac surgery, and the persistent low saturation. Univentricular hearts and comorbidities, I think it is a topic of a different presentation because these patients undergo a series of palliative surgeries and they often face unique, complex, and lifelong set of complications, I will say better, and comorbidities. And we all know that they face problems with protein-losing enteropathy, with chronic pleural effusions, but this is a different kind of presentation, so I will not get into detail I just mentioned. So, in summary, the clinical impact of comorbidities in children with severe congenital heart disease and how we manage with these patients is a challenge. I would like to summarize and say that the neurodevelopmental comorbidity has got a great impact on school and their independence. Extracardiac and genetic anomalies increase the perioperative mortality, and of course, all these things with failure to thrive that is high in infants increase ICU stays. So what is needed to be done? Multidisciplinary management, the need for coordinated care among cardiologists, pediatricians, neurologists, nutritionists, and psychologists, and of course, family education and always support programs. To conclude, the prevalence of comorbidities in children with congenital heart disease is high, even higher than in adults. Up to 90% of children will have at least one comorbidity. Genetic syndromes, prematurity, and perinatal issues are more frequent and increase surgical mortality. More complex cardiac defects are associated with a higher number of comorbidities. And comorbidities significantly affect health outcomes and quality of life. So long-term follow-up is crucial, and multidisciplinary team needs to be aware of all these things as survival rates continue to improve and we have got adults with repaired congenital heart disease. Thank you very much.
Thank you, Professor Kavga. It's really interesting, very interesting, the comorbidities in cardiological, in congenital heart disease. I'm a neonatologist, and we can find it quite often. And you gave us the chance to search more. Any other question?
First of all, congratulations. Excellent presentation. So I'm very happy when I gave you this topic. Okay, I was sure that you will do this excellent presentation you did. The question is, are the pediatricians in Greece trained to provide with primary care these patients? And what happens to these patients? Who takes care of these patients? And the policy of going not to a multidisciplinary team, but to different specialists that do not communicate between them. Is it for the benefit of the family and the child?
Thank you very much for the question. I think this is the great challenge here. Who will be in charge of these patients? So they have got a congenital heart disease. They are babies with heart defects, but it's not only the pediatric cardiologist that needs to be aware of this patient. It's the pediatrician who has to be aware of all these complications, is the neonatologist, is the psychiatrist. So this is the great challenge, I think, in Greece. And I am an optimistic person. I think that we all try, but in lack of centers of excellence and centers of, in lack of a center that all these kids can be under the umbrella of this center, I think we can miss things, and the follow-up maybe is not great as it should be in Greece.
If I can ask another question, the president of the Perinatology Association of Greece is present. So I would like to ask her, what is the policy of your association towards a multidisciplinary team to take care of these patients?
It's a good chance. It's a good chance now to do it. I think it is important, and we have to hurry on because we don't have recording we don't have a recording. I mean, in all Greece, every department has its own record. So it's like in Vermont Center, like somewhere there in Europe, they record, I think, all the children. They have this congenital heart disease and other comorbidities. It's a great chance now. Thank you. Thank you, Asmor.
Thank you very much.
Congratulations and thank you.
Congratulations.
Maro.
Professor Kavga, thank you very much.
Thank you. I wish I was there. Sorry for not being able to be there with you. Thanks. Bye.
Bye-bye.
Thank you very much. So the next speech is, sorry, excuse me, Dr. Vlahovic from Montenegro. It's a pediatric cardiologist of the Clinical Center of Montenegro. The topic is the importance, assessment, and treatment of malnutrition in children with congenital heart disease.